Good afternoon, everyone. My name is Allison Cavanaugh. I head up marketing here at the American Telemedicine Association, and thank you so much for joining us today. It's my pleasure to welcome you to the 4th Annual Telehealth Awareness Week. This is a national platform created by the ATA to raise awareness about the many ways that telehealth supports access to quality care for diverse patient and provider communities. In today's webinar, we'll be hearing from a panel of experts about the smart hospital approach to digital health and systems thinking. So a couple of quick notes. You can check out any other events that have happened at Telehealth Awareness Week by visiting telehealthawareness.org. Events from this past week will be provided in a recorded format. Additionally, don't miss our other ATA events scheduled through the end of the year. These include our 2 Insight Summits, a Health Anywhere Insight Summit and Virtual Nursing Insight Summit, both of which are in Dallas, Texas in November. And of course, the EDGE Policy Conference in Washington, D.C. in December. A few additional housekeeping items. Webinar attendees for this session are in listen-only mode. If you'd like to submit a question to our speakers, please use the Q&A function at the bottom of your screen. This webinar is being recorded. A link to the recording will be emailed to registrants following the event. And as I mentioned, you can also see a list of other resources and other Telehealth Awareness Week events. It's been a long week, guys, sorry, at telehealthawareness.org. So to find out more about the ATA and our work, or if you're interested in becoming an ATA member, please visit our website or contact us by email at info@americantelemed.org. And so now I'd like to introduce our webinar host, Ann Mon-Johnson, CEO of the ATA, who will kick off today's session.
Thank you so much, Allison, and welcome everyone to this wonderful webinar. I'm excited about hosting this and moderating it. And I will also say that it is the last webinar that we're doing for Telehealth Awareness Week. So thank you to this amazing group of panelists. Let me quickly go through the agenda that we have. And on the next slide, just showing you the flow of the conversation. We'll introduce the panelists or have them introduce themselves. And then you'll see that each of them are going to have a different spotlight. So we'll talk about Guthrie, we'll talk about the Smart Hospital Realized, and then the Workforce Reinvented. And there'll be a discussion and then closing. So as Allison mentioned, the Q&A function is there for you to submit questions. We welcome that. And so let's get started. So this is really a great one. Let me introduce Terry. So Terry, you introduce yourself, and then we'll let the panelists take it from there.
Sure. Good afternoon. I'm Terry Kautz. I'm the Chief Digital Information Officer at the Guthrie Clinic. We serve in the New York and PA regions in the southern northern interior of those 2 regions. I'm a nurse by background. And not only do I have the CIO responsibilities, but I have the digital transformation responsibilities at our organization.
And I'm Stephanie Lahr. I am the president of Artisight. I'm an internal medicine physician by background. Spent quite a bit of my career in the intersection of technology and healthcare delivery and roles like the CIO and CMIO. And I'm excited to be able to share some of our story with you today, too.
And good afternoon. Thank you for having me. I am Corey Skurlock. I am the CEO and founder of Equitable Medical. I'm a critical care physician by training. I've been involved with telehealth for about 25 years and completed about 300 implementations. Thanks again.
So we get to talk a little bit about Guthrie. Guthrie is a integrated health system. We again serve our patients in the New York and PA, southern northern tier of those 2 states, a very rural area. We cover about a 10,000 square mile region. We have 6 hospitals, 3 in New York and 3 in PA, and about 40 multi-specialty clinics across that region. And we have home health, hospice, long-term care in our facility as well. And as you can imagine, we really set out on a vision on serving all of our patients where they wanted to be served, which started us on our journey to the Pulse Center. Do you want to go to the next slide? So we are just entering our 3rd year of our 5-year strategic plan. And I get the honor of leading the innovative care delivery pillar which is highlighted there in yellow. And really, our desire is to serve every patient every time, which is part of our mission statement. And how we do that is through access. And we really truly believe that technology can enable this access. And we embarked on a journey to do so with the Guthrie Pulse Center. Next slide. And so our Guthrie Pulse Center is a centralized virtual command center that houses both virtual components of care, but also operational components. We have centralized bed planning. We have our ECWM partnership, which provides virtual intensivists helping cover an EICU. We have a telesitter program. We have virtual med surge and virtual ICU nurses. They are discrete because they have very different functions in that center. We have a centralized transfer center that monitors all of our transfers, not only within our facility, but in and out of our facility, and then centralized telemetry. Actually, since this slide has been put together, we also have a patient navigator that's helping us with some care transition activity for some of our chronically ill patients. And with this approach, we're building off of the synergies of all of those different departments. Instead of housing them in different siloed areas, we're using them to facilitate care in our facility. And that's why we called it the Guthrie Pulse Center. It's literally checking the pulse of our organization, maximizing our resources at the bed level, at the staffing level, at the patient level, and making sure that that patient gets the right care in the right location at the right time. And a perfect example of that is if you have a teletech who is monitoring a patient that has a rhythm that might be a little bit suspicious, they can quickly look over to their left, talk to a ICU nurse, ask about that status of that patient, even pull up the camera view, see if that patient, have a visualization of that patient, and make sure that that patient gets the escalation at the right time. Next slide. And the reason why we started with these elements, because you can start all kinds of different ways, is because we really felt that we needed to serve the patients in the acute care setting a little bit differently. We have a tertiary hospital that is a trauma 1 hospital, but of course you only have so many resources, so many beds. And what we were finding is that we had a lot of patients being flooded to that area, having long holds in our EDs, maybe not even providing access. So some of the patients that were trying to be transferred into our center was not getting that access that they deserved. And sometimes we were losing patients outside. And so we wanted to support our caregivers by adding on intensivists. We partnered with ECWM to do that so that we can have 24/7 coverage. Only one of our hospitals out of the 6 had on-site intensivists. The rest were hospitalists. So even though we had ICUs at the other facilities, it was a lower level ICU, and a lot of things got transferred out because the hospitalists did not feel comfortable taking care of those patients. We added on virtual med surge and virtual ICU nurses, primarily because we had an exodus after COVID, and our ICUs were highly dependent on travelers, and that did not have a good impact on our quality of care. And so we really looked at how do we address that, giving them a lifeline out to help, making sure that we can recruit back into into the ICU. And by reducing the need on travelers, we were able to increase the quality outcomes that we have established for our organization. Our telesitters also support our caregivers in the way that they can now monitor many patients instead of a one-to-one sit. So before, and this is actually how we started our journey, is because we had lots of patients that needed covered. And there was many that were not being covered appropriately because we just didn't have the staff to do so. So we, started our partnership with Artisite. We deployed cameras in our facility, and we were able to, instead of one-to-one coverage, we were able to cover 16 patients per one staff member, leaving the other staff members, the other 15, to actually provide real hands-on care. So putting those care partners back into the facility, also impacting our quality metrics, because things that were not being done before, like baths and walking the patients and some of those other things, can now be done because they actually had the hands to do that. And then we really started thinking about how do we address our need to serve every patient. And we had a transfer center. It was primarily Robert Packer focused, which was our tertiary center. We moved that to our command center, and we opened it up to our whole facility, really being an air traffic control for our hospital, allowing us to make sure that we had the right patient in the right bed. And sometimes that meant diverting to a different hospital, but making sure that they provided the level of care that they needed. Added on the centralized bed coordination, making sure that we was able to escalate when a provider may not feel like they were appropriately being placed, or maybe a nurse didn't necessarily say that her bed was open, and now we can staff appropriately. And then we really wanted to elevate the care, again, through the patient experience, real-time monitoring using the technology, embedding sepsis alerts and some other, and then our pharmacy integration, where we are making sure that our patients know the medications that they're taking. They can even get the medications delivered to their bedside, and then also having that support at home. So wanting to really look at all of our other pillars on how the innovative care can actually support those pillars as well. Next slide. And this is some metrics. I know it's really hard to see, but for a remote sitter, it seems like such a simple task that you would have a screen and you're able to see, more patients, and you're monitoring those patients through cameras. But really, with the solution that we have, it has AI built on top of it. It provides some assistance to enable that care team to making sure that they are able to address those patients that may be moving in their bed or may have a shift in their bed, to make sure that we can provide intervention. But as you can see on that graph on the left-hand side, it was the increase of use of remote sitter. So you can see it grew over time. There was some change management there, and we had to educate on the appropriate application of that. On this next graph, you see that there is a decrease in that in-sitter usage. And not that patients weren't being covered, but patients were being covered, and those care partners, again, were able to actually provide hands-on care. And that's a real true ROI, because if you think about how how you pay a staff member, the 1:16 ratio allows for you to use the 15 other staff members in other value-added areas. But I think the thing that is really, really important is the graph on the bottom, and you can see that we, on that gray line, we've had no falls with injury related to the remote sitter usage. And you can see that it continued to decline with actual total falls and near misses. Next slide. Another thing that we're really proud of is the fact that we had targets. So as we put together the Pulse Center, we actually put together a pro forma. What were the things that we thought that we can influence by adding these different components or these different departments into the command center? And one of the things that we decided to look at with our ECWM partnership is, how do we reduce the length of stay in the ICU? And we picked the ICU in particular because there was, length of stay is a problem across all hospital systems. We recognize that there's lots of activities that are happening to reduce length of stay overall. And so we didn't want to double dip, or we didn't want to double count. We wanted to really have true value on this. And so, before we started, we were upwards above 3 average days length of stay. And now we're down to 2.33. We've been able to hold that. And the reason why we've been able to do that is we partnered with ECWM. We've set processes around and protocols around how do we influence that particular length of stay. Can we allow them to intervene the minute that patient is identified as an ICU patient? So sometimes they're in the ED for a little bit of time, but can they go into the ED, start that care, have our virtual nurses also start that care, so that lifts and shifts that responsibility off of the ED nurses and the ED providers, and those patients actually get real ICU care because they're being managed appropriately. And it really has had an impact. We also have seen through our transfers, so some of our patients that would have actually transferred, we've been able to keep in place. So even in our critical access hospital, they've been able to stay there because our intensivists come in, they help provide and they help manage with the support of the staff that are on site to actually keep those patients close. They don't have unnecessary transfers and their length of stay is not impacted. Next slide. This is kind of an eyesore as well, but I wanted to talk a little bit about our virtual nurse program. And, you know, there's a lot of ways that you can use a virtual nurse. Our virtual nurses actually are part of the care team. And when I talked a little bit earlier about the sense that our virtual nurses have two, you know, med-surg and ICUs have two different kind of roles. Our ICU nurses actually have patient assignments. They are assigned a true patient. They are part of that care team. They monitor them 24/7, eyes on glass, including their biometric data. Our med-surg nurses, however, are very task-oriented, so they have assignments by hospital. They either get called into the room or based on a protocol, they call into a room, and they do things that are listed here on the right-hand side. All of these things are value added because it lifts and shifts away from the bedside nurse. And we've been able to show that this actually saves real nursing time. We have actually invited some of our lawmakers into our hospital to see it, because, you know, as we get a little bit further into the realm of mandatory nursing hours, we really want to educate them around, you know, the fact that these are actually nursing hours. They provide real time. We have not reduced our staffing numbers, but what we've been able to do is reduce the time that they actually have to spend in the chart. We reduce the time that the patient's waiting. We're increasing throughput, and this data that's being collected proves that. Next slide. So the impact, as you can see, we really partnered with two groups that allows us to scale and have some flexibility to be a little bit more adaptive to how we function and how we want to serve our patients. We're improving our resource utilization. We're streamlining our operations, and we measure this and report out on it on a daily basis in our huddle. And then we have a monthly report out to our ELT. And then we're enhancing our patient monitoring. And overall, all of this impacts the patient experience and the patient quality outcomes that we're experiencing at our hospital. Next slide. We do have some future planning. So we are adding workplace safety. As I'm sure everybody is experiencing, caregivers are in a space where it sometimes isn't safe. Our patients are a little bit more violent than they have been in the past. And so we're using Artisight to help us with alerting that there's help needed in the room. We're getting ready to deploy things that will help us monitor auditing activities like hand washing. We have a program called eye care, which is how we talk to and introduce our patients. We want to try to monitor that knock on the door, which is the first step of entering into a room, to make sure that our providers and our caregivers are being respectful of patient space. We're looking at further care model redesign around how do we utilize virtual respiratory therapy, making sure that those mundane tasks are done at a lower skill level, and that our respiratory therapists, which are hard to come by, actually have the higher functioning task, and they can do that remotely. We have already added our patient navigator. We're looking at centralizing EBS and transport in the same space, and then again, turning on the staff duress. And really, the outcomes that we're trying to provide is, enhancing our discharge process. We want to support even in the home. So looking at home health and hospice, how do we utilize similar technology? Can we have our pulse center be the first call to help alleviate some of that burden with our home health and hospice nurses. Also using the same pulse center to develop a remote patient monitoring plan, and then developing a cell of service, which we're looking at how do we, in rural communities, how do we support some of these smaller rural hospitals that don't have these kind of services and be able to provide that kind of service to them using our technology. Next slide.
So this is where I get to jump in, and I think an amazing part of being able to come into this story next is we heard from Terry about the variety of complex challenges that are facing all of our healthcare systems today, and the reality is visionary leadership that Terry and the rest of the health system leaders at Guthrie provide is a cornerstone of that success. The clinical teams that have to make reality of those visions are another pillar of that success, and sort of sandwiched in the middle is technology that really is going to enable those things to happen, because the smart hospital and artificial intelligence, they're not the destination, but they certainly are the foundational tool set that are going to be needed to provide this kind of really remarkable care transformation as we look to our future. Next slide. So let's talk a little bit about what is a smart hospital. I think it's one of those things that people hear a lot about. It's kind of a buzzword that's out there, but really knowing what does that mean, how does it fit, and what do I have to do to have one is worth spending a few minutes on. So a smart hospital really is about leveraging ambient sensor technology of a variety of different kinds. You see some examples listed here, like cameras and speakers, microphones, things that can tell where things are in space, our TLS and ultra wideband systems, and bringing forward insights or gathering information from those ambient technologies and creating new information, new insights, new recommendations, predictions that can help streamline care, provide efficiency and high quality, and do that across all of the various different care settings. So whether that's in the inpatient setting, where a lot of the work that we've been working with Terry and the team at Guthrie has centered around, but that could also be in operating rooms, that could be in clinics, it could be in a parking garage if that's really where you need to come up with optimization. But how do we smartly gather and collect data and create new insights from it that can create improvements across a health system? Next slide. So one of the important elements that we think about a smart hospital and a smart hospital platform is, we heard Terry talk about their beginning in this investment and this adventure with addressing their challenges in patient sitting or patient safety, and moving from an inpatient or an in-person one-on-one sitter to this broader monitoring. That was the use case that for Guthrie created an opportunity where we could deploy this sensor technology. It's a fallacy to think, or it's la land to suggest that this isn't going to require financial investments to get to this point. And so those financial investments have to be justified and have to have a return on that investment. And a platform approach allows you to identify that initial first use case that's going to create the understanding and the actual ROI. And then once that technology sits in place, you can now leverage it for so many more things. We heard Terry talk about all of the different things that we're collaborating on across a number of different environments. And really, again, that is the purpose of a platform. And when you think about some of the challenges that are facing us in healthcare today, things like staff burnout, staff safety, clinical quality, the ROI for a particular tool is much harder to demonstrate. And doing those with one point solution after another will take more than all of the career time any of us have left. So if we're going to move further faster, leveraging a platform that can get you started, build the ROI, build the trust, because we're going to need to talk about some of that as well. If we're going to have a smart hospital system dependent on cameras and speakers deployed in our clinical environments, we have to build trust around how to do that. So using a platform approach allows each organization to identify where to start, how to do that, build that use case, and then move into the harder problems that they want to solve. Next slide. When we think about then ultimately, what is a smart hospital? A smart hospital is the key to solving this problem. How do we bring the joy back to medicine, back to healthcare? In order to do that, we have to help our clinicians. Our clinicians are 70% of the workforce, and most automation that is brought into the clinical environment to date is not directed at our clinicians. It's amazing work, around automating in revenue cycle, medical records, denials, insurance claims. That's all fabulous work, but the 70% of our workforce who are clinicians, they need automation too, and it has to be effective. It has to be trustworthy. And a smart hospital platform is how we untether documentation burdens from our clinicians. It's how we reduce burnout and reduce the cognitive load, because medicine gets more complex every day. Those clinicians need to be able to assimilate more information, and we need to stop collecting that information and requiring that assimilation on the backs of our clinicians and give them real tools that will help them move further faster. So next slide. How do we do it? Where do we start? Well, spoiler alert, we don't start with AI. We start with some really foundational pieces that Terry was able to highlight. First, we get around this concept and start socializing with people that the reality is in our healthcare environments, there's going to be cameras and speakers deployed throughout. And we're not doing that to be big brother or to discipline people. We're doing it to bring them smart automation. Our clinicians leverage their senses of seeing and hearing and speaking every day. We can't bring smart automation to them unless that automation incorporates the ability to see and hear and speak in the same way that our clinicians do. So we bring in cameras and speakers. We leverage a TV for the two-way video. And through that interaction and through that technology and those investments, we now have to think about what are all of the ways that we can leverage those same investments for multiple things. We also create that trusted relationship of why is that camera there? What is the speaker listening to? How we're not recording, but we're really just learning in this digital window. We allow nurses to just see and hear into the room and understand kind of what's happening, get used to that, let our patients get used to that. And then once we've created that, and then maybe take it to the next level of using that same technology for our telehealth platform, bringing our specialists into the room, bringing our nurses and other clinicians like pharmacists and therapists and anyone else, care managers who may need access into the room but might be able to do that in a remote way. Bring all of that together, leverage that same investment for the same thing. And then we get the beautiful synergy of being able to leverage artificial intelligence. Because for artificial intelligence to work in a healthcare environment, it has to be built there. It has to be built there and trained there and trusted there. So we can't take an algorithm that came from a lab or came from some publicly created algorithm developer and think that we're going to put it in healthcare and have it trusted and have it work. But if we have nurses that are virtual nurses interacting with bedside nurses, interacting with patients and families, and using that technology to deliver care and getting the benefit of that, but in the background, leveraging tools like computer vision and natural language processing to figure out how to understand with technology what's happening, then we can bring in automation. Then we can bring in things like fall algorithms that help that person that's monitoring those 16 patients to reduce their cognitive burden and really be able to see the thing that needs to happen. That we can help the nurses who are collaborating on the care for the patient get their documentation done without anybody touching a keyboard. How we can bring together insights from information that comes from the EHR with information that we're gathering in the room and help those care managers figure out what's the next best step for this patient. What are they going to need when they transition out of our environment? All of this can come together in a smart hospital platform and allow us to really advance the care of patients, again, not because of the smart hospital platform, not because of the AI, but because we're really allowing our clinical teams to be the best that they can possibly be and do the work that they were trained to do. Next slide. So as we think about specifically for nursing, what that looks like, and again, this adoption strategy is so important because people, process, and very third technology is as important as we think about this kind of technology, if not more so. Because again, it has to be trusted or it won't be used. So with our nursing staff, we talked about this, we allow them to see into the room and understand what's happening. They change their workflows in order to be able to, because they have that added information, they start working with another caregiver in a remote and virtual fashion. And then the sky's really the limit because those caregivers who now trust that technology actually come forward and say to the leaders in those health systems and the leaders at the technology companies supporting it, I think the technology could maybe help me do this. And that's where every great idea about how we're going to bring automation into healthcare is going to come from. It's going to come from the bedside. It's going to come from our clinicians. So then it's just a matter, next slide, of doing this all across our health system. This happens in our patient rooms. This can happen in our operating rooms. This can happen in our clinics. Not only it can, it must. This must happen in our future in order to keep our clinicians practicing, to keep our patients safe, and to deliver the high quality care that we all know that we want for our own families and deserve. Thank you.
Okay, thank you, Stephanie. That was a nice lead in. I'm going to talk less about technology and more about people and process. So I'm going to talk about how the workforce blends into a smart hospital concept. But when we talk about workforce, we're really talking about the lack of a workforce. So we'll spend a little bit of time on physician shortages, but also nursing shortages and tech shortages as well, and ancillary services on top of that. The other part of this is process. And so when you're doing clinical process design as part of any telehealth program, we think you should really build in a concept of patient flow into that because it has great KPI. It's a great KPI. It has immediate ROI, whether it's financial, it has financial benefits, it has direct care benefits. And if performed correctly, it benefits the staff and produces burnout. So next slide, please. I don't typically read like the titles of slides, but this is one's a good one to focus on. So the smart hospital is truly at the intersection of two of the biggest trends in healthcare today. Number one, how do we redesign our workforce? Or really, it's how do we deal with the challenges of having a limited workforce? And then number two, how do we redesign our virtual care coming out of the pandemic? So let's focus on the workforce first. So, what started 25 years ago as a shortage of specialists in rural areas has now moved to urban areas and has now moved beyond specialists into just generalists and now our nursing staff. And as I mentioned before, ancillary services like sitters and techs and all forms of healthcare. The lack of the workforce causes delays in patient flow, and we'll define that in a couple of slides, which really increase complication rates, increase length of stay, have very harmful effects for hospitals, both in terms of patient care, but also in terms of financial reimbursement. And then what we see in terms of the transfer process is often in the hub and spoke model, the hub is overloaded and congested with patients who are probably too low acuity and actually dragging down the CMI of the hospital system. And the spokes are relatively underloaded and a ghost town at night, mostly due to lack of specialists and staff. And so, we're moving on to virtual care. We're now, I think, at the 26th year of the first tele-ICU or the anniversary of the first tele-ICU. So telehealth's not a new concept. I think what's different coming out of the pandemic is prior to the pandemic and even during the pandemic, if a hospital, and again, we're talking on the acute care side, if a hospital had an ICU problem, they bought a niche product or they developed their virtual ICU in a silo-based system, right? That product just dealt with the ICU. If they had a hospitalist problem, they probably bought a telehospitalist program. And what happened is we have a lot of niche products or best-in-breed products that don't really communicate across the whole spectrum of admission to discharge. And so coming out of the pandemic, what hospitals will want is a platform, much like Terry and Stephanie mentioned, a platform that covers a patient from admission to discharge, one that's modular, one that allows you to innovate, one that's flexible. And that's what they're going to want in their virtual care too. They don't want fragmented partnerships. They don't want disconnected telehealth programs. They want connection. They want a partner that can take risks with them and a partner that can help them move the patient through their whole system. Next slide, please. I'm going to now focus on, at least what we mean by patient flow and help define what we're talking about when we bring it up. But first and foremost, patient flow. And again, we're talking on inside the hospital space. First and foremost, patient flow means getting the right patient, the right care at the right place at the right time, and hopefully in the most local environment to them. Much of that starts in the ER. And if you don't have enough staff or you don't have the right kinds of staff, you can get inefficient transfers, meaning patients are inappropriately transferred or patients aren't identified for transfer either way. You get the concept of ER boarding, which is once the decision's been made to admit the patient, but there's no bed, there's capacity issues in the hospital, that patient boards. We know from the medical literature that every hour they board, there's an increased length of stay and increased mortality. Then after that, hospitals face challenges in terms of bottlenecks. The primary bottleneck of any hospital typically is the ICU. If that ICU is not being run 24/7, that can lead to increased lengths of stay, complications, delays in care, increased nosocomial infections, and increased cost. Same thing is true in the med-surg area. If that's not being run appropriately 24/7, that leads to delays in discharges, in which discharges occur in the afternoon, evening versus morning. All that creates net capacity issues and causes a backflow of patient care. This occurs at the same time that the ER is trying to admit patients and the OR is trying to discharge patients. And then finally, we'll just blend in a little bit of care standardization because people forget that around patient flow. But having consistent care standardization protocols and ways of treating patients, not only reduces complexity and cost in terms of pharmaceuticals and other parts of the hospital, but can help patient flow. It can really reduce the length of stay and move the patient more efficiently through your system. So next slide. The next two slides, I'll talk about how telehealth can help with patient flow, and then I'll actually walk you through a case study that came out about 10 years ago, but really articulates it nicely. So first thing, let's go back to the ER. So having telehealth, that focuses on ER-based care can help triage the patient appropriately, identify the patients appropriately. They can see those border patients. There are no geographic barriers for telehealth practitioners. They don't have to walk anywhere, right? They can see the patients regardless of where they are. After that, you want to start focusing on your ICU, providing highly standardized 24/7 care, focused on the admission and discharge process in and out of the ICU, and really driving the patient through the system in the most standardized way. Pushing that out into the med-surg, having 24/7 care, having a telehospitalist that's helping along with a virtual nurse to get the patient discharged and starting the discharge process on admission and really moving them through the system efficiently. And then finally, what's often, I think, one of the most valuable parts of a telehealth team is that they are working in a quiet, non-distracted environment. They don't have many family meetings. They don't have many of the consultants coming by. They can really focus on driving highly standardized care that can really make a difference in terms of preventing complications and driving the patient through the system as much as possible. And they'll also, if they're working at night, they can unload the frontline staff and reduce their burnout rate. So I'm going to spend a minute on the next slide. So next slide, please. There we go. Okay, I know this is a little bit busy, and I'll try to walk everybody through it. But this is a study came out almost 10 years ago now. It's out of UMass, and it really is a flow-based study. And so, it's a longitudinal study over time. It looks at a 10-year period. The first 3 years are 2004 to 2006, pre-tele-ICU. The next phase, they added a tele-ICU into their academic medical center across all their ICUs. It had medical patients, surgical patients, cardiac patients. And then the third phase of it is really when they added a logistics center on top of it, much like Terry's Pulse Center. And Terry used a word that I think is right, air traffic control. In addition to that, they did air traffic control, but they also focused on care standardization. So you get 3 distinct phases: pre-tele-ICU, tele-ICU, then logistics center, which is air traffic control plus care standardization. And they look at this over time. And so if you go to graph B on the top right corner, what you see is they started mapping out case volume coming through their ICU and length of stay. And pre-tele-ICU is actually the wrong way, right? Case volume is low, which is the red, and length of stay is high. After they add the tele-ICU, you start to see length of stay coming down and case volume going up. And I want to be clear on this. During this whole study, they never built another ICU bed, and I'll come back to that in just a second. But then when you add the logistics center, and it's the third phase of that, you really see case volume increase, and you continue to see length of stay go down. So what they're doing is, they're pushing the length of stay down, which is a direct variable cost, and they're increasing the number of cases coming through, so increasing revenue. And the next part of this will show this more nicely. But this is exactly what you want to do in terms of capacity issues and flow issues. Now let's move down into the graph C, which plots per case revenue versus per case cost. So just looking at essentially margin. And what you see is pre-tele-ICU, they're kind of close to each other. There wasn't really that much contribution margin coming out of the ICU, but you'll see a large uptick right on that orange line where per case revenue really increases. Largely that's due to documentation improvements for that particular part of the study. But then the per case revenue continues to increase due to higher CMI patients coming through. And if you look at per case costs, certainly there's a cost to the tele-ICU, building it, all the infrastructure of that, the technology costs, et cetera, the human capital costs as well. But then you see the per case costs start to go down, largely due to all the care standardization projects that the logistics center did. You'll see a little bump there at the end. That was actually a nursing union dispute. It had nothing to do with per case costs. But what you see is direct contribution margin from the ICU going up. And so 2 things to kind of take away from this. Number one, putting this in over a 10-year period had a $50 million contribution margin to it over that 10-year period. And number 2, they will get 2,000 more cases through their ICU annually post this study than they were pre. If they didn't do this, they would have to build 50 additional ICU beds to handle this volume. So again, focusing on patient flow, focusing on care standardization, really optimizing the patient's experience through this. This has direct financial benefits, but it also has the care benefits were a different study, but has direct care benefits as well. And if performed correctly, has benefits to your frontline staff. Next slide, please. I'll finish up with just sort of people, and I'll go back to process again. So on the people side, we're at the beginning, not the end, not even the middle of the physician shortage crisis. We're also at the beginning of the nursing shortage crisis. A couple things driving that. Number one, it's just baby boomer retirement. As baby boomers retire, not only are they taken out of the workforce, but they actually become part of the people we need to take care of. And if you look, when people turn over 65, they start using the hospital and ICU at about 3 times the rate, over 75, 5 times the rate, over 85, 7 times the rate. Second reason we're in shortages of clinicians is burnout. If you look at least for physicians, number 1 cause of burnout, night work. Second most common cause of burnout is not getting along with your colleagues. The third is not getting along with nursing staff. So, if you start doing a lot of nights and you get into fights with your colleagues and you start getting fights with your nurses, there's almost a spiraling effect, and it's hard to pull out of that. And the third thing is geographic maldistribution. Our elderly population tend to live in more rural areas because it's low cost, and our clinical workforce, they live in urban areas. And this just came out of McKinsey, so this was just last week this study came out. But in addition to that, telehealth is one of the ways we're going to solve this problem, but we're also solve it with APPs and nurse practitioners, et cetera. But we have to lean in heavily to technology to solve this. Next slide, please. I'll come back here to process and why we think flow is such a win-win-win scenario. So if you think about patient flow, and if done correctly, you can increase the capacity of your hospital. You reduce the traffic jam that occurs every afternoon when the OR and the ER want to admit patients and there's just not enough beds. If you improve it, you can also focus on it in the ER and improve the patient transfer process and hopefully transfer the right patients to the right place and increase your load balancing. If done correctly, you'll also reduce the length of stay, which has direct financial implications. And if you open up beds, you can bring in net new revenue as well, and that will contribute to improved operating margins. Probably just as importantly, we're all going to be searching for staff. If you can improve your staff's experience, reduce their burnout, reduce your turnover, reduce your absenteeism rate, that's going to have a direct, not only financial impact, but probably care benefit as well. And then sort of moving forward, the reason why we're all here, we want to improve patient care. We want to improve satisfaction. We want patients to get the care as fast and rapidly as possible. So when you're building your telehealth program, I always factor in a large portion in my clinical process design of patient flow. And also, I would strongly recommend building in data analytics around that flow. When telehealth programs fail, it's very rarely due to technology. It's typically due to the clinicians on both sides of the technology not following the same KPIs, not understanding how to work together, not trusting each other, et cetera. And building that into your clinical process design is really important. The other thing I would suggest doing is building in processes and ways to look at this over time and to constantly come back to these two KPIs. So next slide. I want to say thank you, and I'll turn over to Anne for panel discussion.
Gosh, it just had to happen. Thank you, Corey, and thank you, Terry and Stephanie as well. It was a great conversation, and I certainly learned a lot from it, and there's some great lessons to be learned here. So rather than try to pull those out, what I will do instead is ask you guys a couple of questions and encourage our audience to pose questions as well, with the reminder that if we don't get to all of them, I know that Corey and Stephanie and Terry will go ahead and respond to them offline. So Terry, let me start with you. And reflecting on Guthrie Clinic's journey to become a smart hospital, what advice would you give to other healthcare organizations to embark on a similar transformation?
Yeah, I would start with, remember what you're trying to solve for. I think a lot of organizations or even vendors try to sell you on this thought of AI or we can solve your problem. Sometimes you don't even know you have that problem and you're trying to figure out how you can use it because you like the way that it looks. And what we really focused on are, again, like what I talked about early on about the Performa, we wanted to see what we could actually influence. What were the problems we were trying to solve? How were we going to measure it? And then how are we going to kind of circle back and monitor it? And I think, this goes way further than an IT project. This is not an implementation and walk away. This is really about how do you bridge operations using technology to enable care. And, that takes a lot less about the technology and a lot more about the process and the measurement tools. And so really understand your problems. What our problems were may not be what everybody else is facing, and solve for that. I also, there's a lot of vendors out there. So really, really look at what vendors can you use to scale, who are going to be true partners and understand you as an organization and work with you to, the problem solve. I mean, Corey's team sits on our critical care committees. We meet with Artisite on a regular basis to say, this is our strategic plan. How does that align to what you're doing in your organization? And what can we do to marry that? And without that true partnership, you're going to have all these one-offs and maybe, things that don't work all that well. And I would also just say, don't don't underestimate the change management that goes with this. Stephanie talked about it a little bit about, having trust, but it's more than just trust in the cameras. It's trust in the process, trust that they're being heard. How does this impact them? Lots of communication around monitoring and, are we watching them? Is this a big brother kind of thing? Trust in, the fact that our intensivists are remote. Can they build those relationships, be built into our processes and our daily organizational kind of activities? There's a lot of change management around that. And it's not a one and done. It's a lot of kind of like, hey, what's our lessons learned fast and kind of just recourse. But, there's a lot of process improvement that can happen. And, Corey talked about that, about, making sure that, that they're integrated into the system and that they've done that with us. And so just really having true partnerships.
Great points that you've made. And I was struck by your comment at the beginning that you started at a particular point within the patient flow within your organization. But I'm guessing, based on what you're saying, that that's not going to be identical for everyone. And so really, yeah, super helpful.
Yeah.
Stephanie, with the rise of AI and digital health technologies, how do you foresee these innovations shaping the future of smart hospitals? And what are the key opportunities and challenges that healthcare organizations should prepare for?
Yeah, I think, again, this dovetails a little bit off of what Terry was saying. First, there will be investments that have to be made. I sort of foresee that every hospital room in this country will have a camera and a speaker and a microphone in the next 3 to 5 years. There's no way we'll be able to support our clinical caregivers with the tasks that we're asking them to do without bringing in that kind of technology. The challenge when that's new is there's a lot of people who say, well, I don't know, we've been doing it a long time without it. Probably it's okay if we just keep doing it without it, right? And so getting across that hurdle of just because it's coming in new doesn't mean that it's really a requirement, because the evolution of care delivery, it necessitates these kinds of investments. So I think that's where then it comes to choosing the right partner and choosing the right first problem. I think every organization, as they think about artificial intelligence, and again, this dovetails off of something Terry said, and I said earlier, the AI is not the destination. It's a tool set, much like, when we first started talking about cloud's just a different place to, host your information and do computation. It doesn't really matter. That's not the reason to do it isn't to be in the cloud. The reason is because it solves a problem. And so, I think a good place for people to start when we think about AI, because there are a number of places that it can be influential, but we also know that there are going to be risks associated with it. There are going to be things that we have to monitor closely. And then one of the other foundational things that we're going to have to work through is when we think about the data sets that we have, for example, related to predictive analytics, we don't have amazing quality data in all of our health systems, in part because we've been capturing it on the backs of our clinicians. So one of the things I sort of challenge people to think about is, what if we used AI to capture the good data, like a process improvement engineer in every room 24 hours a day, so that then we have a high quality data set, so that then we can go and do the predictions. Because as we move from things like process improvement and friction reduction kinds of algorithms, we move higher risk into the things that actually could affect a patient's life, right? And so if we're going to move on that continuum from those things that reduce friction to those things that actually are maybe making determinations or recommendations about diagnosis and treatment, we have to have a high quality data set. We have to have a trusted system. So think about that AI in that sort of spectrum of starting with some of the things that can help in workflow, build trust, gather good quality data, and then move more heavily into the clinical decision support elements that can support, those kind of more complex decision making.
That's great. And I love how you've talked about, the smart hospital is not the destination. The technology is more the means to the end. I'm putting a little bit of words in your mouth. and then just bringing joy back and using technology to enable that. So I really appreciate that. Corey, in the context of smart hospital development, can you explain the dynamics of virtual care resourcing across the continuum? How does workforce impact organizational telehealth ambitions?
Sure. I think I said this early, I've done 300 implementations. I probably did the first 30 completely wrong. I know I did. And what I realized is, a large part of this is change management and getting the clinical workforce to work effectively with the people at the bedside. And so hiring the right people, who have the right skills to do telehealth. Not all clinical people can, but hiring the right people. We try to hire around the AAA, right? Able, available, and most importantly, maybe amiable. And then developing the right change management skills within your staff. And then finally, something that, I think is really important is not all hospitals face the same challenges. Hospitals have different cultures. Hospitals have different EMRs. They have different technology they pick. Developing pods. We have a pod-based staffing model where our clinicians really always have the same hospitals all the time. One, that's really good because they can learn the culture of the hospital. They can learn the EMR of the hospital. They learn, especially in terms of flow, what the hospital can handle, what it can't. But also the hospital learns them. And it's a win-win. Again, our clinicians benefit because they don't have a lot of passwords. They get to work at the same place all the time. And hopefully the hospital benefits because they develop interpersonal relationships with them that are strong and long-lasting and allow us to do the change management more effectively. But I think the answers to the other questions hit on this quite a bit. Second thing I would say is developing a partner who can help you at multiple places along the way, whether it's the ER, the ICU, med-surg, post-acute even, who's interested in strategy with you, who's interested in partnership with you.
That's great. Thank you. Well, in our limited time, I'm going to give you one question, all of you, and ask you to briefly tell us what one strategy has been most effective in ensuring high levels of engagement and adoption among both clinical and non-clinical teams. Corey, you go first.
Well, the strategy that we use on this, or I guess I use on it, I'll give my answers, heavily investing in data, getting data that can show you, what you're doing well, what you're not doing well, and then blending that in with the clinical design process, which doesn't stop on program initiation. It should continue and be ongoing for as long as the program exists, and bringing that data there, bringing partnership to it. So that's what I think.
Thank you. Stephanie?
I think I can say it with one word: transparency. Right? I think, you have to set a vision and create that vision and explain that vision, but all of this happens better, faster with transparency. Everybody wants to have success. Everybody's working toward a positive end, and engaging people and being transparent about that process is, I think, the key.
Cool. Bring it home for us, Terry. One strategy.
I would say going to workplaces where the work is happening. It is our frontline workers, our nurses, our providers, even our, unit clerks that, they deal with the problems every day. Involve them because they're going to be the ones that they will kill the project just as quick as they will top the project. So involve them early, make sure that they understand, have lots of communication, and can participate in the design.
That's great. Thank you all. This was just a tremendous conversation. For those of you who have questions in the Q&A that we did not get to, we, again, will follow up with you offline. This recording will be made available as well as the slides. And I just can't thank Corey, Stephanie, Terry enough for sharing your wisdom